Hi, everyone. Welcome back. Today, we're joined again by Dr. Eddie Stenehjem to give our weekly update to the community about what's been going on with COVID-19 in the state of Utah. Eddie, thanks again for joining us. As always, we really appreciate your time.
You got it.
So as always with these, I want to start with case counts and kind of the trends from the last week. Again, these numbers are reported from yesterday, not today, just so everyone is aware. But in total, Utah has 42,328 total cases. Yesterday's daily case count was 404. We have 327 deaths in the state, and the hospitalizations are at 2519 for the entire period of time. I want to talk a little bit about testing specifically and the decline of case counts and what that means. Our 7-day average for Intermountain is 26,079 tests per day, and that's a lot lower than it was a couple of weeks ago. So Eddie, let's break that down and talk about what that means.
Yeah, it definitely is worth discussion. So what we've seen is that over the past 7 to 14 days, we've really seen a decline in number of cases per day reported here in Utah. That really being focused on a decrease in Salt Lake County, but other areas as well declining. But you really have to overlay that with now a pretty significant trend in a decrease in actual number of tests. And so obviously if you test less, you're going to find fewer cases, which is going to impact your daily case counts. And so you then have to start looking at some complementary measures. And one of those things that you look at is what is the percent positive of the tests that you're doing. And what we've seen across both Intermountain and across the state is that our percent positive has remained at right about 9 to 10%. That really hasn't changed much since we had a really significant uptake in cases in June after the Memorial Day holiday. And so we'd really like to see that percentage start to decline, because that would really be indicative of a decrease in community-based transmission. And so it really gives us a little pause to say, this is great that cases are going down, but our test positivity rate hasn't changed, which still means that community-based transmission is still present. A couple of the things that we'll really be focusing on is, as these tests or the numbers of positive patients go down, we should start to see a decrease in hospitalizations about 10 to 14 days after that. And so if we're starting to see a decrease in hospitalizations here, kind of starting into this weekend and the next, that may truly be indicative of decreased community-based transmission among patients that are likely to get hospitalized. Okay, so those are the older patients, the ones that are clinically or have more comorbid conditions. It may not show anything about the younger population because they're not likely to get hospitalized. And so it's starting to get complicated in terms of the numbers and the testing. It's good to see the tests going down, but we'd really like to see that test positivity rate go down too, as a true marker of a decrease in community transmission.
Do you think that there is a overall reason why our testing has gone down as well? Are people having this testing fatigue? Are they no longer wanting to get tested? Can you infer any reason about why our testing numbers have gone down so much?
Yeah, it's a really good question, and one that we've been talking a lot about here within Intermountain. There could be a lot of things. One is just COVID-19 fatigue. People are just tired of this, and maybe they're developing symptoms and they're young, and they just say, I know what this is, I'm just going to stay home. I'm not going to get tested. It could also be the impact of, summer vacations. People are out and about, they're just not wanting to get tested. It could also mean that we're seeing less viral transmission in the community. And we're actually seeing a true decrease in spread of coronavirus and maybe even spread of other respiratory viruses because we're all wearing masks. And that is decreasing the amount of respiratory illnesses that is in our community, and decreasing the need to get testing because people aren't having symptoms of cough, shortness of breath, fever, congestion, etc. So I think it's probably all of those things, and we're going to see this being probably a multifactorial kind of issue as we start to head into the fall.
Another thing that I keep seeing out there is a couple of these misinformation pieces floating out about COVID deaths or COVID positive cases, and hospitals actually getting some sort of kickback from those, whether it's classifying someone who passed away as a COVID death, even though they didn't test positive for it, or even inflating the COVID positive numbers. Can you talk a little bit about what Intermountain is doing and kind of debunk that rumor?
Yeah, be happy to. When somebody dies in the hospital from COVID-19, it's not subtle. Typically, when we think of people coming in the hospital and then eventually dying from COVID-19, they come into the hospital, they've got bilateral viral pneumonia, they're on high levels of oxygen, they eventually go on to need to be on a ventilator. Many times they're on the ventilator for weeks, and then either we say, hey, this is medically futile, or the patient has a terminal event that leads to death. That is a COVID-19 death. Those are the deaths that we count as a COVID-19 death. If somebody were to come in and let's say it was in a trauma and got hit by a car, whatever it might be, and led to a fatal outcome, and they happen to get swabbed for COVID-19 because they maybe had a surgery when they got admitted, something like that, but they died from trauma or died from another illness, that's not a COVID-19 death. We only count COVID-19 deaths due to the primary reason of that death being COVID-19. So that's a COVID-19 death. If somebody comes in and dies from something else, and they happen to have COVID-19, we don't count those as a COVID-19 death. And the state, actually, Dr. Dunn actually addressed this in a broadcast not too long ago from her standpoint too, is that the state health department reviews all the COVID-19 deaths to ensure that they truly are from COVID-19 and that COVID-19 just didn't happen to be there as an innocent bystander.
I think it's important too to note that classifying a COVID death as something that it's not wouldn't really help us learn much about what's going on either, because I mean, this virus is still relatively new. It's August. It's been here for about 6 months. So we would still like to learn as much information as possible. So by misrepresenting what happened to someone, it kind of doesn't really help us anyways. So I don't see the reason to why any hospital system would do something like that.
No, I agree. I mean, we are learning so quickly in this area of science and COVID-19 that it does us no good to be misclassifying these outcomes, because these are severe outcomes that we use to look at, how do we predict that? Who's at risk? We have to make sure that those outcomes are sound and valid, and misclassifying people does nobody any good for this. And there's been a lot of, unfortunately, misinformation out there on podcasts, some of which are very, very popular by, very well-known people. And it's not doing us any favors.
Someone also just asked us about the long-term effects of COVID and why we aren't hearing so much about that in maybe the media or through studies. Can you kind of talk about what we know about the long-term effects of COVID if you were to contract it and you don't end up being hospitalized? Is there any sort of research or data yet that suggests that you do have long-term effects?
Yeah, so we definitely know that people that have severe disease, ones that are on a ventilator and have severe lung destruction, it's going to have long-term effects. The interesting part is, what is the long-term effects for people that have mild to moderate disease? Those people that get infected and don't go to the hospital, for example, but have been at home with a prolonged illness. And we're starting to hear more and more reports out on this, that there are likely going to be evidence of some prolonged symptoms and kind of a post-viral syndrome from COVID-19. And it's not going to be super common, but it's probably going to be present. And the challenge in studying this is that you need large populations of mild to moderate people infected, and then follow them for a long period of time to see, what symptoms are there and for how long. And so these are studies that are hard to do and take significant time to actually generate the data to be able to make any sense out of this at all. And so it is something that's of interest for us in terms of, is there an association with chronic fatigue syndrome? Is there association with headaches and kind of all these different symptoms that go into this? So it'll be an area that'll be active in science, and we'll just have to wait and see once we start getting all that data.
Is there any sort of time frame about when we could start to actually be able to collect that type of data? And what's like a good period of time? Is it 2 years, 3 years? When can we actually say, okay, we know a decent enough about the long-term effects that can actually publish something?
Yeah, I think you're going to need to see, a cohort of people that have been mild and moderately infected. You're going to need to follow them for at least 6 months to a year to make any sense of, short-term kind of long-term impacts, which is, 6 months to a year. And so we're going to be a little ways out before we start seeing any kind of data on that. We have seen data coming out from the CDC showing that there's almost 40% of people that get infected with SARS-CoV-2 that still have some symptoms between days 14 and 21. And so, which really highlights how long this virus can cause symptoms. You're talking about, 3 weeks of illness in many people and, about 30 to 40%. So I think we'll start seeing this, but it's going to be a little bit yet.
Someone else just asked a question about COVID death classifications as well. And they asked, are people that are being treated for COVID at home and then suddenly pass considered a COVID death?
Yeah. So, I mean, you'll see, so Intermountain doesn't get those patients, but you'll see in the Salt Lake Trib or online the information of people that have died. And there's plenty of people that are dying from coronavirus not in the hospital. And so those deaths do get reported and get reported to the state. And those deaths are investigated by the state. So, for example, patients that die in a long-term care facility or a skilled nursing facility, those that just don't show up to the hospital because maybe they have chosen that they don't want to go to a hospital, for whatever reason, those cases get investigated by the state health department.
That's good to know. And I think that hopefully clears up some stuff as well. I want to switch topics to masks really quick. We've gotten this question a few times. A lot of gyms are open back up and are requiring masks. And there is a higher risk, or at least there's an understanding of a higher risk at a gym with the heavy breathing. You're usually sweating a lot more. And someone wants to know, if they wear a mask during a workout, are they lowering the risk for themselves of COVID, or are there consequences for wearing a mask while you work out?
So we'll target that first question. Is there consequences for wearing a mask while working out? No, absolutely not. It may be uncomfortable. I don't want to wear a mask when I'm working out. But there's no risk to you as an individual, a medical risk. So that one's easy. No, there's no risk to you as an individual. Are you lowering your risk for acquiring the infection while in a gym while wearing a mask? Yes, probably. I think that the data is, becoming clear that wearing a mask is going to reduce not only your risk of transmitting the infection in the environment, but also getting infected with a coronavirus as well. So I do think if you decide to go to a gym, gyms being relatively high risk, given the fact that there's increased respiration, increased breathing, that you should wear a mask and really try to focus on, in your area that you're working out, being 6 feet from other people. It's going to be really important.
And probably making sure you clean up afterwards as well. I know that in gyms that I've gone to, that was an issue beforehand. So hopefully people are cleaning up after themselves and making sure they leave the station better for the next person as well, because I think that's super important too.
Right.
Something else I want to talk about is why someone should not wear a mask. Are there any sort of medical conditions or exceptions that allows someone to not wear a mask because it poses more of a risk? One of those examples people keep bringing up is asthma and whether or not you should be wearing a mask for that. Do you want to talk a little bit about that?
Yeah, I think we can talk a little bit about it. This is really becoming an issue, especially in children. And so kids are going back to school, and there is a mandate from the governor that all kids are going to be wearing a mask going back to school. And so there's talk about what are medical exemptions for wearing a mask going back to school. First and foremost, these exemptions are going to be rare. And so this is not going to be common. You should not see this commonly impacting children. So medical exemptions for not wearing a mask are going to be very, very rare. They will be discussed with an individual's physician, whether it be a primary care doc, a pediatrician, family practice. Those discussions should be held there. from my perspective, things that would be a potential medical exemption, potentially severe asthma, but it would have to be pretty severe asthma where wearing a mask is going to be restrictive and kind of set you off into an asthma attack. Potentially skin disorders where you're getting, whether it be some kind of dermatitis or inflammation of the skin due to the mask. Those are some things that, we'd be thinking about medical exemption. In the adult world, severe COPD, could be potentially thought of as an exemption. That being said, those are the people that we actually need to wear a mask because they're going to be at the highest risk for a bad outcome if they were to get infected. And so I would just say these exemptions are going to be very, very rare. Talk to your physician about it. You probably shouldn't be seeing a lot of these exempt people in schools.
I also think it's important to note too that if you have those exemptions, you should probably think about whether it's school or not, whether you take the risk to go out in public all the time too. Because like you said, someone that has these medical conditions is probably more at risk for actually contracting the disease and having severe reactions to it. So kind of weighing the pros and cons of is it beneficial or worth it for me to go out in public to do something, whereas I could stay home and make sure that I'm safe as well. I think that's important to
Well
think
said.
about when you're deciding that. I want to talk about school now. We're going to switch gears. So school in Utah starts anywhere from about the next 2 to 3 weeks. And I know a lot of school districts are still figuring everything out. A couple districts just announced they're delaying opening to kind of let teachers prepare a little bit more. I want to talk about it from a teacher perspective first, and then we'll switch to kids a little bit. What is your best piece of advice for a teacher or someone who works in the school district to keep themselves safe when they return to work?
Yeah, we worry a lot about teachers. We worry about teachers and bus drivers and janitorial staff and administration in schools, because there's a large proportion of teachers that fit into high-risk categories where if they were to get infected, they potentially could have a negative outcome. And so that should be a big focus of ours, in addition to the safety of our children. But our children, as we know, aren't as nearly severely affected with this virus as at-risk adults. So when you talk about teachers, things to think about is making sure that your personal protective equipment, whether it be supplied to you by the school or yourselves, that you're comfortable wearing it. And so wearing a mask is absolutely critical in this day and age for teachers. And so having a mask that's well-fitting, that you're comfortable with, that you've practiced wearing. And so when you go back to school and you're having to wear this mask for 8 hours, it's not your first day having to do this. So get some comfort level with that. You could consider eye protection as well, whether that be glasses or a face shield. That is another layer of protection because your eyes are a mucosal surface that, you can transmit virus through. And so I'd be thinking about, can you wear some kind of protective eyewear or face shield in addition to a mask? And then there's been lots of discussion about, can you set up kind of, controls in your classroom, whether it be plexiglass or those types of things. These are going to be really hard to implement and demonstrate the effectiveness. But, maybe you think about that in terms of, is that something that would fit into your classroom? And then the last thing really to be thinking about is how can you as a teacher prepare your classroom for students to be coming in? And so how can you creatively move the desks around to ensure that we are getting some physical distancing between students? Are there things you can do in your classroom to increase ventilation in the classroom to really kind of disseminate any viral particles that are being transmitted by droplets? So can you open your windows? Can you open the door while you're teaching? Just something to improve ventilation. Is there a way to incorporate a fan? Those types of things I'd really be thinking about between now and when you're going back to school.
You brought up the spacing of desks too. The CDC announced that for children, at least in schools, the desks can be 3 to 6 feet away. Is there a reason why that number changed from the 6 feet that we're so used to hearing? Or is it because schools are so small that that's a lot harder to have the 6 feet? Is there a reason for that change?
Yeah, I think it's probably based a lot on just the reality of school classrooms, especially in states and school districts where there's, increased class sizes, Utah being one of them. If you do look at the travel of respiratory droplets that carry SARS-CoV-2, they really start to drop off after 3 feet, and by 6 feet, most of them are out of the air. And so 3 feet is certainly good, 6 feet is better. And so I think this is really just part of the reality of classrooms, with the thought that there is some biologic and scientific evidence that 3 feet is pretty decent in terms of disseminating that kind of cloud of infected droplets.
I want to talk about Georgia really fast. So there was a summer camp that started in Georgia, and they ended up having to shut down. A lot of the campers and counselors tested positive for COVID. And we also had a school district in Georgia that had positive cases, and a classroom had a quarantine. This is just the very beginning of like school type activities kicking off. What have we learned, or what can we learn from the situation in Georgia? And how does that make you feel with students going back to school in a couple of weeks here?
I mean, Georgia's a great example. This was a summer camp with kids between ages of 6 and really 17, and then a number of counselors between like 18 and 21. All of them had to have a negative COVID-19 test within the previous 10 days of coming to the camp. They got to the camp, and then they weren't there for very long before their first positive case came, and they're all left within, I believe it was 5 to 7 days. And if you looked at the attack rates for all of the children that were there, it was upwards of 50% that were infected with COVID-19. And so 51% of kids 6 to 10 were infected with COVID-19 after being at this camp. And a couple things to think about is, what was the community-based transmission in Georgia before this camp started? It's real high. And so Georgia is one of the hotspots for COVID-19. And so they're instituting a camp while community transmission was very high. That's a recipe for disaster. And there wasn't universal masking in place. And in the report, there was talk about plenty of singing and yelling going on. So, this was an area that was a camp being held outdoors, but there was high-risk activity in a very high-risk community, and it led to widespread dissemination of COVID-19. And so, the lessons learned there are that, if you're in a community with high rates of transmission, going back to these type of activities, whether it be a summer camp or school, is going to lead to cases, period. Your community-based transmission is so important. It's going to dictate what you see in these facilities. And it shows that these are high-risk events, even if you're outside. These, singing, yelling, shouting, those things transmit virus. And so it really was a good example of, what can happen, and that plenty of kids got infected.
You also mentioned that they had to get tested 10 days prior. And I think it's important to note that, and this is just in general for testing, if you get tested one day and your results come back negative, it doesn't mean that in between the time your results come back, you didn't contract the disease unless you quarantine. And at that point, you shouldn't get it. But it could be too that a lot of these children or counselors, they were tested 10 days prior, still went about their daily lives, contracted it that way, and then went to the camp. Is that correct?
Yeah, that's absolutely right. And, to add on to that is that, if I go out and I get exposed to somebody with COVID-19 and get infected, I likely will test negative on days 1, 2, 3, and 4 after my infection. And it's not until really day 5 of the incubation period that you start getting virus to the level where you're going to detect it on your tests. And so just because you're tested once doesn't mean you're not going to be positive the next day or the next day. And so, testing is very static. It's a moment in time. And you have to incorporate the incubation period of the virus, and then also your exposure once you've been tested.
I have another quick question about masks too. If your child is hard of hearing, requires some sort of lip reading in order to be able to effectively communicate, or they need some sort of additional help, is there something that they can do as far as wearing a mask or informing their teachers or anything like that, so that if they do go back to school, the in-school process is a little bit easier for them?
Yeah, this is, really where it gets hard. As kids, especially kids with special needs, they rely on facial expressions, whether, it be they get that from social cues, or if they're hard of hearing and they need to lip read. This is really going to be hard for those kids. And that's really where you start thinking about, are those the children and potentially teachers in that classroom that would use face shields? And so a clear face shield that you can see facial expressions. I think that's kind of where the science is headed. There are some clear masks that are being developed. I haven't seen any here in Utah, but I've certainly seen manufacturers having some of those. So those also may be an option as well. And it really gets to the point, though, is if you're going to be using a face shield, whether it be in the teacher or the student, making sure that physical distance is present. Instead of 3 feet, maybe say 6 feet for those with face shields, I think is going to be really important. The data is just not there on face shields. We don't have, data like we do on masks on the usefulness of it, whether it be in controlled studies or whether it be observational studies. And so it's going to be, we need to see some of this data on the effectiveness of that, but it's going to be really challenging. I know as, a physician, I was wearing a mask on rounds a couple of weeks ago and was talking to somebody who was very hard of hearing, and it was really hard to communicate. They couldn't read, my lips. They had a hard time seeing my facial expression or when I started talking. It's going to be challenging for those kids and also for those teachers of those kids.
The next couple of months will definitely be a learning lesson for a lot of school districts too, to figure out what the best way to go forward is too. So hopefully things get better and we'll be able to see some good things happening in the community. I want to talk about two last things. First, I want to talk about antibody testing and just give a brief update. It's been a little bit since we've talked about this. Do we have any further evidence or studies going on that show that we're pushing towards herd immunity? And also, is antibody testing effective, necessary? Who should be getting it?
Yeah, so antibody testing, you heard a lot about it in the media when it first came out as another modality of testing. And then we really haven't heard much about it since then. Antibody testing is fine. You can, do a test to determine whether or not you've been infected with SARS-CoV-2. It usually turns positive about 10 to 14 days after the onset of symptoms. We still don't have any data currently to show that a positive antibody test is indicative of immunity, whether it be a short-term immunity or long-term immunity. We just don't have any data on that in terms of the effectiveness of that. We haven't seen any cases reported, whether it be nationally or internationally, of true reinfection. Somebody who got SARS-CoV-2, fully recovered, and then got it again. We haven't seen that. And so that is encouraging because certainly time has passed, really, especially in Wuhan and in China, where it was ongoing in December and January. And so it's encouraging, but we haven't seen any definitive data to show that a positive antibody response really, truly demonstrates any level of immunity. So right now, the utility of antibody tests are pretty minimal still, aside from just identifying people that got infected. From an individual person perspective, it's not a test that we recommend because it doesn't have any implications on what you can and can't do in the community. You still need to wear a mask. You still need to, follow all the public health principles we've talked about.
The other thing I want to talk about is vaccines. I have a question for you first. So I was doing some research on this about vaccines and how they typically take around 10 years or so to develop, typically. How is it that there is a vaccine that we could potentially put into the market in 2021? How is it being pushed forward so quickly? And what are the repercussions potentially of having a vaccine go into the market that fast?
Yeah, you're right. So typical kind of landscape of vaccine development is about 10 years. And so the FDA has worked with a number of companies to try to really shorten this. And, one of the things initially is that, before you would do tests on the vaccine in non-human primates, essentially monkeys. So you would start with that, and then you would move into phase 1 trials, and it would typically be just a phase 1 trial. Then you would move into a phase 2 trial, and then you move into a phase 3 trial. And now what the FDA is allowing companies to do, because of the public health need for this vaccine, is to initiate non-human primates the same time as you initiate human trials. Okay, so you're testing it in chimpanzees, et cetera, at the same time as you're starting testing in adults, in healthy adults. So that's one way to really minimize that. In addition, they now have created phase 1-2 hybrid trials. And so you can start a trial that's both a phase 1 and phase 2 trial, which allows these trials to really essentially run, in parallel, to be able to finish and then move into phase 3 trials or a phase 2b3 trial. So it really minimizes some of this time in between trials. And what manufacturers are doing is, as they're running their phase 1 or phase 1-2 trial, is they're planning for their phase 3 trial. And so once they finish and they rapidly go in and evaluate their data, they can get approval from the FDA to start their phase 3 trial very, very quickly. And then FDA has gone in and said, these are the requirements for a phase 3 trial to get emergency use authorization at the end of that. And so, it's a 6-month trial, have to have 30,000 volunteers. And this is a trial that people are very interested in. And so it's going to be probably easier for us to enroll interested individuals to be in this trial because of the public health need. And so instead of taking years to enroll 30,000 people, it may only take us months. And it's an infection that's pretty prevalent, so we can actually see outcomes pretty quickly. And then the last thing on that topic is that the pharmaceutical companies, and also being funded by the US government, is taking a risk in the fact that as phase 3 trials are going forward, they're already manufacturing the vaccine. And so right now we have manufacturing plants developing vaccine for Moderna, for Pfizer, for the Oxford vaccine, with the thought and with, leveraging some risk that they're going to find that their vaccine works. And once they get emergency use authorization by the FDA, then they can start distributing. And so lots of things going into this in terms of shortening the duration of time.
As far as who will be eligible or who should get the vaccine, is there going to be any sort of hierarchy on who gets it first and if you should take the vaccine or not when it first comes out?
Yeah, so the simple answer to that is yes. The minute that this vaccine gets approved, there's not going to be a supply that can, cover the entire, U.S. or the world. And so there is going to be some protocol in terms of prioritization of a vaccine. Most likely, we're going to see the state really helping develop those criteria. And it's going to be dependent on how much vaccine the state of Utah gets. We have 3.2 million population. How many vaccine doses are we going to get, and how is the state? And we're certainly more than happy to help work the state through this. But how are we then going to go through and determine who is at high priority for for this vaccine? Most likely, it's going to be essential workers, and so it'll be probably frontline healthcare workers. It will also be those people that are at high risk for developing complications from COVID-19 if they get infected. So that would likely be adults with clinical conditions that put them at high risk. Those are probably the first kind of phase. And then after that, we're really going to have to get into the details of who this vaccine is going to be given to.
I really quickly want to touch on hydroxychloroquine and what's been happening with that specific drug. I know that Intermountain was using it in clinical trials previously, and we're no longer using it. Do you want to talk about kind of what we learned from it and why we're not using it as a therapeutic for COVID-19 anymore?
Yeah. So early on in the epidemic, we were seeing what are called observational cohort trials that had looked at the use of hydroxychloroquine. And so these are trials that are not randomized. They're just looking at, okay, here's a cohort of people that got hydroxychloroquine, and there's a cohort of people that didn't, and let's look at the outcomes at whatever, day 14, day 28. And in those studies, it looked like there may be some kind of signal that there was benefit. And I say maybe because not all of those trials showed benefit. There's plenty that showed either no signal or potentially even harm. And now what we have are randomized controlled trials that studies the impact of hydroxychloroquine in hospitalized patients and also in some other populations as well, being outpatients with mild to moderate disease. And so in those cases, what happens is somebody with COVID-19 gets randomized, either to hydroxychloroquine or not hydroxychloroquine. And now you actually have an experiment that looks at causality and looks at whether or not hydroxychloroquine actually impacts any kind of health-related outcome. And this is an area where it's very clear and that it doesn't. And so in all the studies that we've seen that have been published, and multiple now have been published in journals like New England Journal of Medicine, there's no benefit of hydroxychloroquine in treating mild, moderate, or severe disease in COVID-19. It's very, very clear that in these good clinical trials, there's absolutely no benefit. In addition, a couple other trials came out this past week that looked at using hydroxychloroquine to prevent infection. And so they took people that got exposed to coronavirus and randomized them to either receive hydroxychloroquine or not, to see did hydroxychloroquine prevent them from becoming infected after a high-risk exposure. No benefit at all. Hydroxychloroquine did not prevent them from getting infected. They got infected at the same rate as those that did not take it. And so whether it be in terms of prevention or treatment, hydroxychloroquine really hasn't shown any benefit at all to our patients, and in instances it's caused harm. And so that's the reason why we don't use this medication in either outpatients or inpatients.
I think it's important too for people when they're looking up their own research and trying to figure out and kind of confirm their own reasoning about what's going on, is you look at the dates of when studies are published, because I know there was a New England Journal of Medicine article back in like April that talked about the ineffectiveness of masks, and it was April 1st, and they had to go back in at the end of May and update the studies. So I think it's important when people are looking up studies about therapeutics that you look at the dates of when they were actually ran, because new information every day is coming out. It's still the same year that this has kind of happened. And I know it feels like it's been 5 years, but it's only been a couple of months. So I think it's really important when you look up information, make sure you check the date on it.
Absolutely.
Eddie, is there anything else you want to mention today about what's been going on in the last week?
Yeah, I mean, the focus now is on getting kids back to school. And, that continues to be our singular focus, is to be able to get kids back to school. We can't get kids back to school without decreasing community transmission. And so, as we kind of think about our role in our communities and in the state of Utah, it should really be focused on what am I doing to decrease the community transmission of COVID-19. That should be our singular focus. Because if we can drop our community transmission, get our testing rate down, our cases down, if we can do that, then we can safely get our kids back to school. And if we can safely get our kids back to school, that's when we can really get going back to kind of what we think of as normal. And so these things are so interrelated, and our focus right now is absolutely getting kids back to school, because then parents can get back to work and we can start kind of moving forward. And so I think, as people watch this, it's really to be thinking about what are you doing to really decrease community transmission. And we all have a part in this. So if you are at home and saying, oh, it's not up to me, it is up to you. It is up to you to wear a mask. It's up to you to not gather in large groups. It's up to you to really focus on and decreasing the number of close contacts. And this is all, in an effort to get our kids back to school safely. And I think that's, needs to be our focus as we go through August.
Well, Eddie, thank you so much for joining us. We really appreciate these updates. And a couple of pieces of information for you guys. Primary Children's Hospital actually released a really great Let's Get Back to School PDF that we shared yesterday on Facebook, but you can access it just by going to their website and looking for that piece of information. It talks about if your child should go back to school, the risks associated, and everything like that. We also still have our COVID-19 hotline available. You can call that phone number at 844-442-5224. And our emotional health relief hotline is available 7 days a week from 10 a.m. to 10 p.m. That phone number is 833-442-2211. I also quickly wanted to mention that on August 12th, we will be doing a Facebook Live with Dr. Adam Hirsch and Emily Thorell again to talk about schools and children and COVID-19 COVID-19. We'll put a little bit more details about that around Monday so you can tune in. But Eddie, thank you so much again for joining us, and we'll see you next week.
You got it.